This is Moufida Holubeshen. I'm here to follow up on the last video where I told you all about my diagnosis and treatment options in British Columbia for basal cell carcinoma. And if you recall, there were two options. One was local area wide, and they take out 3 to 4 millimeters of skin near the tumor. And the other one is Mohs, like Mohs the grass. And they take out 2 to 3 millimeters, which they are testing to see if they need to take more or less. They're testing for the cancer, so there's a higher certainty of success. And if you recall, the tumor was 5 millimeters wide in diameter, 3 millimeters deep, and 5 millimeters away from my eye. So with that crushing news of being between a rock and a hard place, I basically feel angry, but also channel my anger into writing this letter to my dermatologist to advocate for myself, as well as while writing this letter, I am able to organize my thoughts, my feelings, and write them down and look at my options. And I'm also researching things. What we come up with is several surgeries are happening in different parts of the world. We know that I can get a surgery in Seattle, for example, within a 2-week turnaround and about $3,000 US, not including travel and accommodation. We know Russia is doing something else, and then there's a photodynamic therapy and, all these different ways of treating basal cell carcinoma. And so I am very happy that I am able to basically exercise one option to get the surgery done quickly if I choose to go that route. And so as I'm crafting my letter to the doctor, I am making all the arguments about how my tumor, as I discovered, grows at a growth rate of 0.5 to 0.7 millimeters per month, which means in a year to a year and a half, that thing's going to be in my eye, in my tear, like the corner of my eye and right into my eye. So I'm alarmed. I'm very upset. And the other thing I find out is that with Mohs surgery, there's reconstructive surgery. I didn't know that. And they do it right then, right after, and you have no idea that that's going to happen. No one tells you this until you get there for the Mohs surgery. So I'm kind of shocked. And the other thing I find out is when the Mohs surgery is on skin that's part of your eyelid structure, the only other compatible skin they can use to graft for the skin they're taking out is skin from your other eyelid. So now I'm really alarmed about the double whammy of having skin taken out from both eyelids. Anyway, so I finished drafting my letter trying to make a case around getting funding for getting the surgery in Seattle. As alarmed as I am, and I'm very alarmed, I thought, okay, I'm feeling better. At least I have some control over these events, and I feel like I can get some health care. So I started looking into the legislation and the rules around filling in for reimbursement for getting the Mohs surgery. And I discovered that the guidelines, which I've posted below, are you have to have, and I'm going to read it to you, if it's immediately threatening, life-threatening, or results in medically significant, irreversible tissue damage. And it talks about Section 2 in the guidelines. Yeah, what's irreversible tissue damage? Do I have to lose my eye? Do I have to have eyes without eyelids? I don't know. So it's very hazy, and as a patient, as a client of the BC healthcare system, I am feeling very vulnerable. So much interpretation, which means no guarantees, and that kind of leaves me with the need to think about things a little bit more, although we were prepared to pay for it and just do it. I parked the letter, and I am sleeping on it before I send it. And because I'm a researcher, I continue researching. And I discover a dermatologist who is in New York who had done a very recent groundbreaking study using Nd:YAG laser to basically remove a basal cell carcinoma, specifically basal cell carcinoma. And she had a 97% success rate, which is very promising. This is a clinical study, and she uses an Nd:YAG laser. And what the Nd:YAG laser does is it basically kills the vessels that are feeding the tumor. And when the tumor can't get blood, it dies. And that's how she has been doing it. And she has this other technology that she's using called optical coherence tomography that allows her to see, and it's the same tool they use for opticians to test your eye, to see if there's still cancer. And so that in this way, she's able to, in one appointment, you go in, she tests where the cancer is, does the laser, and removes the tumor, which is fantastic. It's non-invasive, doesn't take time to do, but there's two catches. She's in New York. I don't know how much it cost, and she doesn't do it near the eye because the Nd:YAG laser, the power on that is 140 joules. So it's extremely powerful, so she doesn't do it near the eye. So I'm reflecting on that, and I'm thinking, yeah, there should be technology like this that's non-invasive. They do it quickly, and that would take care of all of the backlog that we have in BC, especially when you don't have it near your eye, like I did and do, or maybe still do, don't know. And so I'm talking to John about this, and I'm asking him, I said, well, what if, can we get a laser, and can we try this, and what if we got a weaker laser? And so he does what he does best. He gets onto eBay and he starts researching, and he said, yep, I can get a laser. I can get a tattoo removal laser, and that laser is exactly the same technology that the dermatologist in New York is using, except the tattoo removal is 2 joules. So we think to ourselves, we have nothing to lose, really, by safely attempting to try to treat this near the eye with a tattoo removal laser. So stay tuned. Thank you for watching part 2. And if you want to see what happens when a tattoo removal laser meets a basal cell carcinoma, please watch the next video and please hit subscribe. Catch you later.